Hi, this is Neil Hansen. I'm taking you through an aortic runoff CT angiogram. These are very large, complex studies, and as such, I think, especially for junior residents, it intimidates them a little bit. But it's pretty easy. They are just pipes, and you're just telling whether the pipes are open or not. So when you bring up a CT angiogram, there's going to be a very long list of series, many of which are 3D reconstructions. I'll tell you, the 3D reconstructions can be very good to give you a large overview of what's going on. Typically the aorta and pelvic arterial outflow are reconstructed, as are the superficial femoral arteries. Additionally, many places will do reconstruction in the knee, so you can see the tibioperoneal trunks and the proximal aspects of the calf runoff vasculature. So we have all of those. However, I find that most radiologists typically don't even use those for diagnosis. A lot of times surgeons will just use them. They're good to show patients because they're a little easier to understand than axial images. So these are typically single-phase studies that are obtained utilizing a smart prep based off of the abdominal aorta. And to read a runoff, I always start with the vasculature before reading all the incidental findings. So you start with the abdominal aorta as it enters past the diaphragmatic hiatus. And always comment on the celiac axis and superior mesenteric artery. Bringing up a sagittal view is very helpful for looking at the origins of, I find, especially the celiac axis and the superior mesenteric artery. It's one of the things that are on my sagittal view checklist for these studies. You want to make sure they're open and they're not dissected or thrombosed. Next up come the renal arteries, and I like to verify their patency on a coronal view. So there's always a coronal reconstruction, and you can verify that in this case there's kind of an early branching of the right renal artery, which is an anatomic variant, occasionally important if they're going to do like a renal artery bypass. But you can get the best view of the renal artery ostia oftentimes on an axial or a coronal image. As we continue going inferiorly, you can see the origin of the inferior mesenteric artery, which in this case is widely patent. Most of the time these studies are ordered, though, for claudication symptoms or lower extremity trauma. So what the surgeons really want to know about is the lower extremity vasculature. So at this point, once we've reached the aortic bifurcation, I take it side to side. So we'll go through the right side as an example, but really the left side would be done in identical parallel fashion. First, you comment on the right common iliac artery, its bifurcation into internal and external iliac arteries, and then as it crosses the inguinal ligament, it becomes the femoral artery. So everything from the aortic bifurcation through the femoral artery is considered the pelvic arterial outflow. I usually lump that into one kind of paragraph within my reports. I do the abdominal aorta first, then the pelvic arterial outflow for one side, and then the lower extremity runoff for one side, and then the outflow and runoff for the next side. We have templated PowerScribe reports where you can easily just plug and insert the patency of all these vessels. So I'm going to go down the right side here, kind of zoom in and focus on the right. So as you go down the leg, it can oftentimes be hard to remember where you're at. So by convention, if you're talking about stenoses, pseudoaneurysms, or traumatic injury, many people will bring up the scout radiograph so that you can easily tell where you're at. So let's say, for example, I was following the femoral artery down to where it bifurcates. Now we have the profundifemoris artery and the superficial femoral artery. And I go down, and let's just say, for the purposes of discussion, there was a dissection right here. You'd know that it was in the mid-superior femoral artery, but you can be more precise for the surgeon, measure it on the scout, and say it's 24.5 centimeters above the knee joint. And then you can even give them a distance, oftentimes based off of the scout, of how long that narrowing stenosis or vascular injury was. You'll notice as you come down, the superficial femoral artery in this case is widely patent. This is a healthy young person who is kind of incidentally scanned for a traumatic injury. Then as you get down into the lower aspect of the thigh, as the superficial femoral artery swings into the musculature, that's called the adductor hiatus because it's a hiatus around your thigh adductor musculature. At that point, the superficial femoral artery starts to turn into the popliteal artery, which runs obviously right behind your knee joint. So here's the popliteal artery. Popliteal arteries are frequently affected by stenoses and aneurysms, especially in vasculopaths, so it's always important to look specifically there. As we keep going down, we get to the level of the knee joint, right here, and all these perigeniculate collateral vessels arise off of that popliteal artery. The next major thing to evaluate is the runoff in the calf to the foot. So usually a few centimeters below the knee joint, the popliteal artery breaks into two divisions. So that's your anterior tibial artery to the right hand of the screen, and your right hand of the patient, and your tibioperineal trunk, which is to the left. The tibioperineal trunk then bifurcates again into your perineal artery and your posterior tibial artery. And typically I follow all three of these vessels all the way down into the ankle. In this case, they're all patent. Down here to the anterior tibial artery, perineal artery, and posterior tibial artery. It's important to describe bilaterally what runoff there is to their feet. Frequently in diabetics or vasculopaths, you'll have single vessel runoff where the AT, PT, or perineal artery will completely thrombose off in the upper calf. And so a typical impression for a report like this would include, like patent 3-vessel runoff to the right foot, if all 3 vessels are patent, or a single vessel runoff to the right foot, because ulcers are more likely to occur the worse peripheral vascular disease you have. So if someone has a single vessel runoff, it may account for a diabetic foot ulcer, for example.